Walter through this floor. I feel like I get a lot of questions, and this is a good chance for us to get together and kind of hash out this again, because this is really changing a lot of what we do, and I feel like it's really important to kind of go over this so you guys understand a lot of the why of what we're doing and how this kind of came to be. So ERAS stands for Enhanced Recovery After Surgery. I am Emily Lear. Most of you know that. I work with general surgery. I graduated with my bachelor's in 2007. I graduated with my master's in 2014, and my background is ER and ICU nursing. I have no conflict of interest. I'm not trying to sell a product. I'm trying to be unbiased and evidence-based approach to this content. You guys can get CEUs for this. You guys will get a survey about this. You guys will be able to fill that out. Please give me an A+. And then, yeah, North Kansas City Hospital is an approved provider of continuing education for nurses. What is the problem? Major surgery causes a physiological stress response, organ dysfunction, and hormonal and neurological disturbances. This is experienced by the patient as pain, nausea, insomnia, and fatigue. Increased is length of stay for hospital patients. Poor outcomes and increased costs are all a result of this. So why ERAS? ERAS protocols are associated with reduced hospital length of stay and morbidity, faster recovery, comparable or reduced readmission rates, and cost of savings compared with the traditional care in both old and young patients. So what is traditional practice? Prolonged fasting prior to surgery, extensive periods of bed rest, use of bowel preparations, insertion of drains following surgery, and lots of IV fluids and narcotic use. Revolutionary changes in surgery. So back in the 1990s, laparoscopic surgery kind of became the new technique. It became very widely adopted. Kind of at the same time, anesthesia was able to come up with a lot more regional anesthetic techniques that help with pain postoperatively. This led to dramatic improvements in postoperative recovery, but not good enough. Let's talk about paralytic ileus. This is the big thing that we see a lot on this floor, on the fifth floor, following our gut surgeries that we do. This is a disruption in normal motility of bowel. The small bowel is not talking to the large bowel. Peristalsis isn't happening. This is exhibited by abdominal bloating, hiccups, nausea, and vomiting. The risk of this following our surgeries is about 12 to 17%, which is kind of a large statistic in how many patients can actually get this. I feel like this is a pretty good representation, maybe a little bit more. So risk factors for prolonged ileus include, obviously, abdominal surgery, GI surgery, open cases, we make the large incisions, delayed oral nutrition, NG tube use, peritonitis, low albumin, excessive IV fluids, bleeding, and then, of course, narcotic use. Okay, so organizing. So Dr. Kellett, he was a surgeon from Denmark. Him and a group of surgeons band together, and they came up with this ERAS-like study program. This was kind of focusing on the quality of the recovery, not the speed. They focused on pain control, early ambulation, and reducing postoperative ileus. Additional and specialists were kind of combined together. They were examining the other aspects of this, which included metabolic and endocrine factors, perioperative nutrition, contributing factors to inflammation, protein metabolism in surgical patients with cancer, and side effects of fasting. So the big picture, it aims at reducing stress on the body by avoiding fasting, inclusion of carbohydrate fluids before surgery, oral fluids, regional anesthetic techniques, early patient mobilization, and preemptive treatment of postoperative pain and nausea. This ERAS protocol arrived to North Kansas City in the fall of last year. A team was formed comprised of pharmacy, nutrition, anesthesia, pre-surgical clinic, pre-op, operating room, general surgery, 5th floor, 8th floor, and 10th floor directors. A big group. The initial focus was colorectal surgery with Dr. Oza and Dr. Mizrahi serving as physician champions. So ERAS starts with us. This is at this time just for elective cases. They come to our office. We, like for a colon cancer, for an example, they'll come to us for a new diagnosed tumor. Surgeon sits down with them, says we need to remove part of your colon. We do this thing called ERAS. It's a thing that we're piloting. It helps with postoperative period. You'll go home sooner, your pain is better, so forth. So the patient usually has to be on board because this takes a lot of coordination and cooperation from them to stick to this, otherwise it doesn't work as well. So they discuss the goals of care, how it works. They discuss all the nutrition components to this, and then the compliance. So they sit down with our pre-surgical, our surgery scheduler, Jen, and then we would make an appointment in the pre-surgical clinic. Before surgery, especially like our big colon surgery and so forth, we would only kind of send our more high-risk patients to there to get lab work done and screening. If you are a pretty healthy patient, you didn't necessarily need that prior to having surgery, but now they're all going to go to pre-surgical testing for this ERAS. They're going to get a lot of information here. They're going to get a pamphlet, kind of discusses everything, and some questions are able to be answered for the patient. They get a CBC, they get a creatinine, and then they get the 5-day supply of the Impact shakes. These shakes contain nucleotides, L-arginine, and omega-3 fatty acids. So we're kind of boosting their nutrition prior to surgery. They've seen that this really improves outcomes, especially with wound healing and fighting infection, increases gut oxygenation, and colonic microperfusion. So we're kind of teeing up their nutrition even before they get to surgery. The day before surgery, we still do bowel preps on our bowel surgeries. We still have better outcomes with this, so we're continuing that. However, these patients tend to be our more dehydrated patients. But we can allow them to have clear liquids up until 2 hours before surgery. So this NPO after midnight is different. It has to be clear. It cannot be red popsicles. It has to be a clear fluid, but they can have it up until 2 hours. About 3 hours prior to surgery, so sometimes this is pretty early for them. They're instructed to take this carbohydrate loading shake, and this is shown to decrease the stress of surgery on the body. So it decreases nausea, decreases vomiting, reduces infection, and improves hydration. As soon as they get here, these patients, because they're usually asked to come about an hour and a half, 2 hours prior to surgery, and so that cutoff of having clear liquids kind of shuts off at that time, but we quickly give them Tylenol, gabapentin, Entereg, and Celebrex, and IV Zofran prior to surgery. So we kind of get them nice and teed up. Anesthesia shown pre-op. So before we roll these patients back to the operating room, surgeons given the green light. Anesthesia goes in with an ultrasound machine. They're doing nerve blocks for us. They're starting to do this with orthopedics, but I'm not going to get into that because I don't know much about that. But for us, they will go in through the abdomen. They're going to look for the transverse abdominal plane. They're going to inject a local anesthetic to help block the spinal nerves that wrap around the front, and then it decreases their sensation of the belly. This is usually only takes about 10 to 15 minutes. It works really well. I will say that some of our very large patients, we are unable to safely do that because they cannot reach the area to effectively block the patient. There's not like a BMI cutoff, but there are some patients that have gone through this protocol that we have ineffectively been able to block. So just kind of keep that in mind, because these patients may seem to have more pain than the patients who did receive a block. So just be kind of cognizant that they might be kind of more on their call light than the typical ERAS patient, but you'll have to look back at anesthesiology's notes and see that that wasn't doable. That's about it. And the operating room. This changed a lot of things for our CRNAs as well. So we're not giving hardly as much IV fluids as before, decreasing narcotics. We're actually giving Toradol within surgery, which is usually something that we never did before. It's got an antiplatelet effect, increases bleeding, but on most patients it's pretty safe to give. They're also getting an IV dose of Tylenol within surgery. We almost always inject local into our surgical sites even before ERAS, but now we're doing that as well. A patient, based off of their BMI, can only have so much local anesthetics. We take that into consideration when we're also doing a block, that we have to adjust how much that we're actually injecting into their incisions when we close up. They're also giving ketamine, dexamethasone, and low-dose lidocaine infusions. I'm not sure that we're doing all that quite yet here, but this is something that's being done at other hospitals. And then, of course, maintenance of normothermia, keeping patients at a good temperature. We always try to aim for laparoscopic surgery. This is not always feasible given the patient's history and what's going on, but of course laparoscopic surgery decreases length of stay and improves pain control after surgery. Early ambulation. This is kind of where you guys start to kind of come into the scene. Early and progressive patient mobilization is associated with decreased length of stay. We try to get them out of bed 30 minutes to arriving to this floor. They're recovering in the PACU for an hour or two. They come up here. The idea is to get them moving within 3 hours of surgery. We need to be pretty diligent about this. This is an expectation that is set with the patient at our pre-surgical appointment and needs to be discussed from the whole time. So their expectation is that they are going to be up and walking, and several times a day. So our nurse assistants will have to be very helpful. Early initiation of diet. So this is also a big change for us. They were typically NPO sips with chips for about 48 hours. especially after our colon resections, but now they're allowed to have a clear liquid diet immediately after surgery, as soon as they're awake and can maintain their airway, of course. But and technically the order is written advanced as tolerated, so these patients are kind of advancing, in theory, to a regular diet, even potentially the next day. I kind of caution them. I think it's kind of new for me. I feel a little adherent to say, go ahead and have a cheeseburger next day after colon resection. I say try to stick with soft foods. I don't know. It just makes me a little nervous. But studies have shown that they can advance a regular diet pretty well as soon as they can, and it works. Entereg. This was a new drug for me. I had to kind of learn about it. I don't know if any of you guys are familiar with Relistor, which is a subcu injection that we would give for patients, and it would kind of block the opioid effect within the abdomen. This is similar to that, only this is an oral medication. They're going to be getting this here before surgery, and then I believe twice a day while they're here. Toradol. Let's talk about this. I had a patient the other day that didn't receive Toradol for almost 24 hours because there was a misconception that this patient had to have a creatinine within 48 hours of giving Toradol. They changed this for the ERAS protocol. It now has to be within 30 days. So if you guys are looking for a creatinine or creatinine clearance, just change your data range. It should be dated back to their pre-surgical testing when they went there for lab work. So as long as they have one at that date, then we should go ahead and be safe to give the Toradol. Does it make sense?
Is pharmacy on board with that?
Pharmacy
a lot of times say...
Yes, correct. Pharmacy is aware. They've been part of this process the whole time. I think this was the first time they had really adjusted that just the literature showed that if we have a patient that has never had a documented history of any type of renal impairment, and the creatinine is within 30 days, that it would be reasonable to give Toradol for this. Because otherwise we discussed the difficulty of getting the patient here immediate for surgery and getting an immediate stacked creatinine just so we can give intraoperative Toradol. And then also we're giving the Celebrex, which is also an NSAID. So this was something that I think that this is just special to this ERAS. I don't know if they're going forward with that with any non-ERAS patient that needs Toradol. That still might hold up the 48 hours. The idea for all of this is to exhaust all of our ERAS ways of attempting pain control before moving on to narcotics, but we still will be giving IV fentanyl, and we still will be offering oxycodone without Tylenol as an adjunct for pain relief if they still have significant amount of pain. So just do us a favor and make sure that you guys are looking at all of the things that's ERAS, that's non-narcotic, that we can give before moving on to opioids. Celebrex. This is an NSAID. I just went over this. This has less risk of perioperative bleeding, so we are giving this to the patient. They're getting 200 milligrams daily. That kind of brings up a point, though. We know that there's patients out there who cannot have NSAIDs either for a documented history of ulcers or various reasons. ERAS is like a pie. There's several pieces to it. If we can't do one piece of the pie, it doesn't mean that we can't do all of it. We're still hitting some of these other points with ERAS, still hoping for better outcomes, and it still is helping. But there are patients who cannot be blocked, who cannot have NSAIDs, who cannot have Tylenol if they have a documented liver dysfunction. So this is just keep that in mind, that we have to keep trudging forward, and it still does make an impact. IV fluids. We're decreasing the amount of IV fluids we're given. If you think about it, the patients are allowed to have clear liquids pretty well up until surgery, and they're immediately allowed to have clear liquids after surgery. I realize that some patients are still going to be nauseated. They're not going to be able to have the oral diet. If we run into more severe issues with vomiting, or they really are going a period of time without a lot of oral intake, we will increase their fluids as needed. We haven't really seen this so far. It's not been any issue, so we're prepared to take care of the patients who are nauseated and not going to be taking in an oral diet. If we need to increase their fluids, we will, but we're starting off with a 50 ml per hour rate. Urinary catheters, this is another significant change. Our protocol before was 6 a.m. post-op day 2. This is basically, as soon as the patient can get up and walk and they can feasibly pee, we're taking out the catheter. There's only about a 5% risk of a patient having urinary retention following catheter removal. I know we always are cognizant of that. Please bladder scan these patients. If we suspect that they're not urinating, and they should be, but the Foley needs to come out ASAP. So to kind of summarize everything, patients are allowed to have clear liquids immediately following surgery, and diet is advanced as tolerated. They are going to be getting round-the-clock Toradol and Tylenol, as well as gabapentin. The oxycodone and the fentanyl is going to be ordered PRN for breakthrough pain. Obviously, if we run into allergies, we'll deal with it, but this is just kind of a standard mix. They are going to be getting these impact shakes to the floor. Somebody will be coming by and dropping them off at some point, either right before surgery, so they're ready to go when the patient's there. They're taking these 3 times a day for 5 days following surgery. And also, I'll offer ice packs. I know you guys know this on a cervical floor, but this seems to really help some patients. Auditing. There's going to be quality auditing going over this. I know that we're looking at data even as we've just done a small handful of cases, looking at pain, comfort, postoperatively, ambulation. Are we getting these patients up, their oral intake, length of stay, complications, readmissions, and then rounding by the nurse and the educator. They're going by and talking with these patients and talking with the nurses, making sure that everything is going smoothly. Okay, the impact of ERAS. Researchers at the University of Virginia Medical Center, they studied 109 ERAS patients compared to 98 patients in a traditional group. Decreased length of stay by 2.2 days. Overall complication rate was down by 17%. Satisfaction with pain control increased by 55% and reduced healthcare costs by about $7,000 per patient. So this is really good data to suggest that this is worthwhile. So always good to know what we're doing. This is an adjunct onto this. I like to kind of go over this. This is kind of a separate issue from ERAS, but I feel like this is something that I've seen on the floor and I'd like to talk about. JP drains. I see a lot of this lately, and I feel like it's kind of catching on. I kind of see it more often. This is the wrong way to apply suction. There are studies to show that this applying suction is not nearly as effective as the traditional way. It may seem kind of like a minor matter, but we really care about how much is coming out of those drains, what is coming out of those drains, the consistency. We make clinical decisions based off of these drains, either whether it be the quality or the quantity of what's in it. So just so you know, it would just be helpful if you pass along, if you see these, just correct them and just push them in the old way. You will see a difference in your output. That's my little thing on JP drains. Any questions about that? No. And then nasogastric tubes. I see so many either mistakes or connections aren't right, or there's just a lot of problems with NG tubes in general. I could probably spend a whole lecture kind of going over NG tube insertion and helping out nurses. I've done a million of them. But connections is the biggest problem. Even more so than the JP drains, we make a lot of decisions based off of the NG output. This can tell us a lot of things. And when the patient who is obstructed goes without proper NG sectioning for an entire shift, which sometimes does happen because either the connections weren't on, the canister did not match the right suction apparatus, tube was misplaced, it had to come out. I mean, a lot of it, this isn't a blame, this isn't necessarily nursing error, but this is just being very aware that something that has several connection points, several settings, there's a lot that can go wrong. If somebody is obstructed, they're nauseated, they're hiccuping, they're going to vomit on us, it's very important that all of these are connected and it's actually working properly. The amount that comes out of this makes a difference in what we do with that patient. It is definitely a factor when we're looking at, does this patient need to be reoperated on? Is this obstruction worsening? Is it improving? Are we seeing routine malfunction? Because when we see a decrease in NG output and we start to see flatulence or passing stool, we know that bowel function is returning. But if this is falsely low and our other exam shows us more distension, then there's a problem, and we really need to do the patients a favor. They have a significant amount of relief when NG works properly. They have a lot less pain, they have a lot less nausea, they overall do feel better. As barbaric as it is to have one of these in your nose and down your stomach and complaining of sore throat, these do work well, and it's important that we make sure that all of the connections work properly. And you start from the wall. Make sure, sometimes it's even just the wall section needs to be plugged in tighter. I mean, there are a lot of connection points. We just need to make sure at every beginning of every shift and even halfway through the shift. Our output should never be 0. We make 2 liters of gastric juices every day. So if the NG tube is in the stomach and it is working properly, we should have a minimal of a couple hundred with good bowel function. Okay? So I should never come in and say, well, there was nothing out of the NG. That is a problem. Okay? Never hesitate to call us to get an x-ray. Never hesitate to call me. I can help and manipulate these. It's a special... Hi! That's not a toy. Let's go this way. So just keep this in mind. This makes a big difference to us. I can't stress on that enough. Any questions about NG tubes? If you ever have problems with insertion, just call me. I've got a million tricks. I can give a lecture on it. I don't care what I would need to do, but I'm willing to be helpful. I think that is about it. Questions? I had to do this. Yeah.
You should give a lecture on NG insertion, I think.
Yeah, I'd be happy to.
Especially for a lot of like our new nurses and just like, I don't know.
Yes, I've done it here on the floor. They're difficult insertions because sometimes we get to the point where our only option is like interventional radiology, which we don't, is quite excessive for NG tube placement. And sometimes that's what we have to do if patients have sinus surgery and so forth. But there's a lot of ways that we can improve that skill, and it's not pretty, it's not fun, but I have a lot of experience doing it, and I mean, if I can't do it, then we can move on to something different, but I'd be happy to give a whole lecture on that, or give an instructional video, because, I don't know, it's not something I like to do, but when I see somebody struggling with how to do it, I'm like, alright, listen, this is like a 15-step thing. You gotta go in there with suction, you gotta have a water, you gotta have a straw, you gotta have a scope, you gotta have your thing, like, you gotta be ready to go, and seeing some nurses not even having that, it definitely brings up a good educational point, but I'd be willing to go into that someday. Any questions about ERAS?
I have a question.
Sure.
Prior to their surgery, this patient have been educated that they're going to get up within 3 hours?
Yes.
They're going to eat?
Yes. Now, whether that goes in one ear or not the other, I can't prove that, but they are going to be getting this information not only from my surgeon, but from pre-surgical testing. They're going to get a whole pamphlet on it. So yes, the expectation is that they come in and that they're going to get up and walk and that they're going to have something to drink. Now, have we had patients that just outright refuse? Of course, we really don't have any control over, they have the choice to refuse that if they wish. But this works to their benefit. We just need to stress, sometimes the patient just needs to understand why. I know we've had family members at times that, hey, well, we think physicians get you up too soon. And I know we've all heard that banter, but we just need to come at them politely and say, research really does suggest that outcomes improve, patient will do better, your pain will improve. We do this for a reason. This isn't torture. So, I mean, if we try to educate the patients that we do this because science suggests that this is the better way of doing it, sometimes they're more apt. And we will take anything that we can get, dangle them. If they are refusing to get up and walk, just make a compromise with them. Let's just sit you up on this side of the bed and sit for a few minutes. Maybe let's get into the chair and make strategic goals and write it on that whiteboard. If they see it up there written, it is not easy for them to forget. Okay? If they understand the why, sometimes we can win them over. Any other questions? Okay, thank you guys for coming.
Thank you.
You guys will be getting an email, so please fill it out, and then you can print off your receipt.
I know, but do you like all your
Sarah, I need to sign that too.